Good afternoon. The case is a 65-year-old obese female with a body mass index of 32, long-standing hypertension, and dyspnea on exertion. As physicians and cardiologists, when a 65-year-old lady complains of breathlessness on exertion, naturally we will be considering various differential diagnoses. One is obesity itself. Second is she is not tuned to exercise, there is deconditioning. Other factors like anemia or respiratory problem. And when we come to cardiac disease, we will be considering coronary artery disease because dyspnea may be an angina equivalent. A valvular heart disease like severe aortic stenosis, cardiomyopathy, pulmonary hypertension, or a cardiac failure situation. So let us look at the cardiac failure situation, because if you see the rest of the story, Kiran had given me BNP levels as well as echo. Heart failure by definition currently is a clinical syndrome. If the patient has one or more signs and or symptoms of heart failure, you can consider heart failure. This could be due to a structural or functional abnormality of the heart, where you should have elevated natriuretic peptides or an echo evidence of pulmonary or systemic congestion. And all of you know this classification: reduced ejection fraction less than 40%, preserved ejection fraction more than 50%, mildly reduced ejection fraction in between the two. So this patient probably falls into this category because the ejection fraction is given as 64%. She has grade 2 diastolic dysfunction, E by E prime 16, LA volume index elevated and BNP elevated. Even though some of these terms may not be very familiar to the physician crowd here, I will just touch upon that. What is this diastolic dysfunction and how we evaluate that? Ejection fraction is known to all of you. You know it is low, there is heart failure. But how we evaluate the diastolic function is very, very important. Let us have a look at this cartoon, Tom blowing up the balloon. The balloon is the LV. Tom's mouth is the LA and his lungs are the lungs. So whenever the balloon is very stiff, you can know that you will have to blow very hard, or the pressure in the LA will go up and the LA will dilate, and this will be transmitted to the lungs so that they become dyspneic and they develop all the features of heart failure. So it's essentially the non-compliance of the ventricle that leads to all these problems. The LV is very stiff. So how do you assess that? You assess the flow of air into the balloon, or how fast the balloon is recoiling. We measure the flow of blood into the LV across the mitral valve by putting a Doppler signal there. Doppler measures the velocity of flow. We just keep the probe there and you can see the arrow. We will pick up the velocity of how fast the blood is moving from LA to LV. You will see a picture like this in the echocardiogram. You have two velocities. One is called the E velocity, that is the maximum flow, and second is the A velocity, that is due to the atrium pumping the blood at the end of diastole. If the ventricle is compliant, E will be large, A will be small. As diastolic dysfunction sets in, E becomes smaller. The blood doesn't flow naturally, the atrium has to pump. So the E by A ratio reverses. You can also know the velocity of movement of tissues, not only of the blood, by putting something called tissue Doppler at the mitral valve level. You can put it on the septal region as shown on the first panel here, or you can put it on the lateral wall as shown in the second panel there. That will show a picture like this. Initially the mitral valve will move towards the apex as the ventricle contracts, then it goes back. That is called the E prime velocity. And after that, when the atrium contracts, it moves forward and then comes back. That is the A prime velocity. So when the relaxation is not good, the E prime velocity will be low. The movement back will be low. And naturally when the E prime decreases, the ratio of E by E prime increases. So you need not remember all the values, just know that we can know the diastolic function by looking at the flow of blood across the mitral valve as well as the movement of the mitral annulus and by plotting a ratio between the two. We can also measure the volume of the left atrium as shown there in the echo picture in two views and index it to the body mass, especially in an obese patient, because the volume may be large in an obese patient. Index it to the body mass. So let us come back to our case. Ejection fraction 64, you all agree with that it's a normal ejection fraction. Just now I told the E by E prime, it is high. Anything more than 14 indicates significant diastolic dysfunction. LA volume index is also elevated. So this patient has got a heart failure with preserved ejection fraction. Is there actually such an entity, heart failure with preserved ejection fraction? People are always doubting. Is it a reality or is it a myth? Because it is always associated with obesity, hypertension, dyslipidemia. Actually, a metabolic conundrum is there. A group of diseases, metabolic problems are there. Even liver disease, non-alcoholic steatohepatitis, liver disease is also associated. But now it is considered as a reality. We have different scoring systems which help you to diagnose that. We have got diagnostic algorithms as well as specific treatment coming up. One of the scoring systems is, the name is almost similar, HFpEF, HFpEF. It is only a mnemonic based on some clinical variables and the values for that. H2 stands for heavy, that is a body mass index more than 30, or a hypertensive. F stands for atrial fibrillation, P for pulmonary hypertension, E for an elderly person, and the last F for the filling pressure. Just now I told you the E by E prime ratio, if it is more than 9. So if you add up all the points, it will come to 9. And the probability of a heart failure with preserved ejection fraction is like this. If it is in the 6 to 9 range points, it is heart failure with preserved ejection fraction. Of course, by ruling out other causes, a patient with a hemoglobin of 4 or 5, you cannot say that it is HFpEF. You have to rule out all the other causes. 0 to 1, you can rule out a HFpEF, and 2 to 5, it is intermediate. The second scoring system is called HFpEF, again, almost similar to the condition, where you look at the functional aspects, the morphology, as well as the biomarkers in sinus rhythm, as well as in atrial fibrillation. Again, it is divided into major and minor criteria. Functional is decided by the E prime, the E by E prime velocity and all those things. Morphology by the LA volume as the LV mass. Biomarker by the pro-BNP and the BNP with slightly higher values in atrial fibrillation. And if the values are lower, you call them minor criteria. If there are more than 5 points, you diagnose as HFpEF. If it is 2 to 4 points, you go for further evaluation. So the first one is rather clinical. This is more based on investigations. So let us take our case and do the scoring for that. This is the first scoring system, the HFpEF system. Our patient is heavy, she is hypertensive, she is elderly, and she has a higher filling pressures as shown by E prime ratio of around 14. So she gets 5 points, which brings her into the intermediate group. In the intermediate group, it is not a purely diagnostic scoring system. So you see whether the patient has got a chronic kidney disease. If the patient has got a chronic kidney disease, she requires special investigations in the cath lab. You have to take a catheter into the heart, measure the filling pressures during rest as well as during exercise. So you have to refer her. If she doesn't have CKD, one can look at a NT-proBNP as well as the BNP. If they are low, again she requires an invasive assessment. If high, one can diagnose HFpEF. Let us take her to the second scoring system, the HFpEF scoring system. She is having functional 2 points, biomarker 2 points, and a minor point, so 5 points, which puts her into the diagnostic category of HFpEF. So that's what I said. This is not a myth now, it's a reality. You can score clinically, you can score based on the investigations. What is the treatment? Previously people used to say there is no treatment for HFpEF. You cannot use the drugs that are used in heart failure with the reduced ejection fraction. Here, only lifestyle modification. Well, that is very important. You have to control the obesity, control the hypertension, control the atrial fibrillation, so the other comorbidities. You can use diuretics to reduce the volume overload, as in reduced ejection fraction. Judiciously, if needed, you can give diuretics. SGLT2 inhibitors, today morning we had a talk on that. They are to be started in all patients unless there is a contraindication. Check the body mass index. If it is more than 30, we can use semaglutide or tirzepatide. This has also been discussed in the morning, the benefits of these drugs in HFpEF. Aim for a 10% weight loss, and even with a 10% weight loss, if symptoms are present, one can start mineralocorticoid receptor antagonists, especially finerenone. On the other hand, if the body mass index is less than 30, there is not much role for the GLP-1 agonist. We can straight away go for finerenone. What about ARNI, which is the first drug in reduced ejection fraction? It's a class 2B indication, can be tried if ejection fraction is low, that is close to 50%, as well as in females. So soon we may get pictures like this, which are present in the heart failure with reduced ejection fraction. The first pillar is already there, SGLT2. The second pillar is also coming up, GLP-1 agonist. Mineralocorticoid receptor antagonist, finerenone, and ARNI in selected subset of patients, of course, on the base of diuretics as well as lifestyle measures and comorbidity control. So, this is the last slide. You have two types of heart failure, one in which the heart is dilated with a low ejection fraction, the other where the heart is stiff with a normal ejection fraction but still unable to relax and take up the blood without increasing the filling pressures. We have to identify the subset, use the scoring system, and use the treatment algorithm that is present nowadays. Thank you.